Okay. My next co-instructor will be Dr. UNNIKRISHNAN NAIR. He is the chairman and medical director of Chaitanya Group of Eye Hospitals from Kerala. He is based at Trivandrum. He is an excellent vitreosurgeon, retina surgeon, and a good. His keen interest is in retinal imaging. Over to you, Unni. He will be talking to us on topic on vitrectomy for myopic macular holes and tractional maculopathy.
Good afternoon, everybody. And myopia seems to be a hot topic today. So many people in the hall today, but please enjoy the session. So I'm not doing a typical. My talk has a bit of physics, a bit of pathology, and all those things. But I mean, if you want to really understand what happens in traction maculopathy is the hottest thing in myopia now, barring low dose atropine. So we have a definition for myopia that is spherical, like what do you say, more than anything more than minus 626. Just let's leave all of these things. So we go directionally to tractional myopathy. We have a few conditions we are dealing with. We're dealing with foveal schisis, macular schisis, and retinoschisis, 3 schisises. For the sake of myopic maculopathy, we have to kind of think of these 3 things as a continuum. Foveal schisis, something the disease process starts centrally and progresses towards a more global affection, that is retinoschisis. Then you have foveal detachments and you have large retinal detachments, and then you have the macular holes, which it's not a sideways thing, it's a vertical thing, a lamellar to a full thickness macular hole. The funny thing you have to imagine here is that the perpendicular force causes the disease to progress sidewards. So as the perpendicular, I'll tell you what the perpendicular force. As the perpendicular force increases, the foveal schisis converts to a macular schisis, converts to a retinoschisis. Now let's look at the funny thing, the tangential force. As the tangential force increases, the vertical component increases. From a lamellar component, it becomes a full thickness component. So that's the simple code you keep in your mind about myopic traction maculopathy. So basically there are 2 forces happening. One is the sclera and one is the vitreous. The retina and the choroid are the poor bystanders that are affected by it. Sclera by scleral elongation and deformation, and vitreous changes. So what happens, the retina has got an inherent stickiness. It's called eventually the Muller cells are responsible for keeping the retina together, and that's the force that pulls everything towards the inside of the retina. So it's called the intraretinal force. And everything working opposite to it is an extraretinal force. That is, you have tangentially you have the vitreous working, and perpendicularly you have the sclera working and the elongation of the eye working. So as I said, there are preretinal forces and there are subretinal forces working in opposite directions. And what keeps the retina together is 1, the Muller cells, 2, the blood vessels, and all these things that keep it together. Other incidental factors are when there is excessive choroidal atrophy, the vasculature is affected, and that also weakens the retina. So this is just a few very simple slides. Foveal schisis, in which splitting of the retina, you can have outer foveal schisis and inner foveal schisis, and then you can have extensive foveal schisis going beyond to retinoschisis. And after that, you have a foveal detachment, in which you have something separated from the retina, separated from the RP, starting as an outer lamellar, may proceed, have a inner lamellar, or may proceed to a full thickness. And this is what we talked about, lamellar macular holes, and finally the full thickness macular holes. The full thickness macular holes are those which have a tendency to form RDs and those which do not have a tendency to form retinal detachments. So the newer concept of MTM is that all these things are not separate. It is a continuum, starting from localized schisis to more extensive schisis to detachment to macular holes to retinal detachment. So it's just something waiting to happen. The time frame can be up to say it's 5+ years. So therein lies the concept of whether it has to be treated. Now, what is important here? This is a very cool thing to know about. You have a perpendicular force. Now, when the perpendicular force increases and the person gets a schisis, and it increases and he gets a detachment, and then when he gets a detachment, the perpendicular force is relieved, which means that when a person gets a foveal detachment, the schisis is relieved. So that is how the physics works in this condition. So as the disease gets worse, components of the disease get better. So now you have, we'll come to skip this side. This was the original classification of the entire myopic. It's called the ATN classification. There are atrophic events, there are tractional events, and there are neovascular events. That's the ATN. So then, of which the tractional events have been reclassified into the MTM staging system. So the MSS1 is the stage 1, in which you have an inner or outer schisis, which is localized. Then, as you can imagine, the schisis improves and increases, and it goes to just the outer retinal schisis. Then it goes to a macular detachment, and then after some time the schisis goes away and it's just a detachment. It's a progression. And to this you add 1A, 1B, 1C. A is intact fovea, a normal looking fovea. B is when there's a lamellar hole, and C is when there's a full thickness hole. So when you say it's 1 or 2A, it's just a schisis. 1 or 2B, it's a schisis with a lamellar, or C is a schisis with a detachment. When you go on to 3, you're starting to get a foveal detachment, and when you go on to the stage 4, it's a full-blown retinal detachment. So these are some of the pictures. You can see from the pictures, starting from one side, you have 1A, 1B, and 1, 2, and 3. And all of them, the presence, you look at them vertically, then you'll get the picture. Schisis more, detachment starting, full detachment. Again, in the center part, it's the same sequence, normal fovea, lamellar hole, and macular hole. So that's how it goes. Vertically and horizontally, look at the chart, you'll get a good idea about the MTM classification. Additional effects are ERMs and splitting in the photoreceptors. So this is how the management started. People started shortening the eye. They did macular buckles. They used gas. They used silicone oil, heavy silicone oil. Started ILM peeling. Then went on to foveal sparing ILM peeling and ILM flaps. So this is how eventually the treatment progressed. And then what they found out that when you did too much vitrectomy in all these conditions, you ended up with lots of retinal detachments, and you ended up with lots of iatrogenic holes. Okay. So there was a stop on the treatment, and buckles came back. So that in the progression of the treatment, macular buckles and vitrectomy with macular buckles have taken a whole circle, and they've come back. There's a beautiful logic behind this, okay? And this is the logic. I'll just skip this now. Okay. So what is the goal of surgery? As I said, the goals of surgery are not to treat a detachment or treat a hole. The goal of surgery today is to give good vision, one, and to prevent the progression of tractional maculopathy. I told you tractional maculopathy is a progressive disease. So when you see a patient in stage 2, there is a very good reason to do surgery so that he does not progress to a further stage, which is inevitable. This is interesting. If you have two components, that is, if you have a lamellar hole and if you have a schisis, I told you the schisis is because of perpendicular force and the lamellar is because of the tangential. If you treat only the perpendicular force, if you slap in a macular buckle and you do not take care of the tangential force will make the lamellar hole enlarge. Okay, so that is a key concept here. Identify the type of force that produces a type of pathology and treat both of them if required. Again, if a patient has a macular schisis and you just do a vitrectomy, you will not relieve that particular part. The macular schisis will remain. The lamellar hole component will change for a temporary period of time. The presence of a macular hole changes the whole thing. The presence of a macular hole means you have to do a vitrectomy. The question is that whether you add a buckle or not is a secondary question. And this is an example of one of those things where a vitrectomy and a macular buckle has been done. So the choice of surgery between macular buckles and vitrectomy, one choice pointing towards adding a vitrectomy to a buckle is the speed of resolution. Macular buckles, sometimes the fluid in the schisis takes a very long time to resolve. Macular atrophy does not change the choice of surgery. It only changes the choice whether you want to do surgery in the presence of extreme macular atrophy. So all of this was created by the Parolini group, and it's a beautiful thing. I'll just go through this. Stage 1A, as I said, it's just schisis, inner schisis, observation is adequate. Stage 1B and 1C, you forget the macular traction component part and treat it like a lamellar hole or a full thickness macular hole. So that is what has been. So it's a PPV or a PPV plus MB if you have significantly. In stage 2, when there is more extensive schisis, you have to treat it. Depending on the stage, you can still observe, or you can do macular buckle first to relieve the schisis, and a delayed PPV if the lamellar hole is increasing, or you can do it as a combined procedure. In stage 3, obviously there's a detachment, and a combined surgery or a macular buckle is the essential surgery to treat a macular detachment. If there is an epiretinal membrane or surface changes, you can add a PPV to it. But if there is a hole or a lamellar, PPV automatically gets added to it. So this is an example where a macular buckle was done. You can see a macular buckle was done. There was a residual ERM, and that was done by a PPV later. So stage 3 and stage 4, the treatment is the same. It is a macular buckle combined with a coincidental or a delayed PPV depending on the macular condition. That's a whole gamut. If this is a good picture to take, if you want to take, it's a whole, everything is here on the, from stage 1 to stage 4. Okay, so the anatomical restoration and visual acuity are the main key features. The difficulties during surgery are the length of the globe, reaching your making your instruments reach. Visualization of the ILM is very poor because it's very thin, so staining may not happen. Presence of vitreous dominance after you've done a vitrectomy can interfere with this. Laser doesn't take up because the choroidal pigment, the pigmentation, the RPE pigmentation, all of these are problems of surgery. So I just, can I have 2 more minutes just to...
Yeah, please go ahead.
Yeah. So this is a surgery which I'd like to show you. This was, there's a macular hole somewhere in a bit of fluid of detachment. So the first, one of the key points is that always use IVTA. You need to stain the vitreous and know what is happening properly. So this was IVTA stained. This is how dirty it looked after multiple patches of IVTA staining. So on top of that, we put blue also. What the advantage of, this is called double staining. The advantage of double staining is that once you get the edge, you see the blue, but in areas where the blue doesn't stain, you see the splattering of the triamcinolone. That's the advantage of doing a double staining in myopic conditions. So here it took a long time. The membranes were very tough and very, so it took a long time to peel off all the membranes. Very gently it was peeled off from the posterior pole. And then there was a lot of residual fluid, and then we used a very nice instrument called Thomas cannula, large fluted with 39 gauge cannula, which can just penetrate and pull the fluid off the posterior pole to make it flat. Otherwise, you can imagine if you do a tamponade, the fluid is not going to escape because it's lying within the staphyloma like a cup. So this is just quickly another surgery in which we've stained with this thing, and this is a macular hole, detachment with a macular hole. We've done ILM peeling, because around the macular hole, and created a retinotomy by the side. You don't usually drain through the macular hole when you want to settle a retina, so you take a peripheral drainage retinotomy and you flatten the retina after that. The last slide is a quick one. This is another example of a double staining. You see there's a little amount of blue and a little splattering of IVTA. That's how you see all the membranes were quite clearly. And this is a very useful way of staining myopic ILMs. You can see both the tissues are stained with both splattering of white crystals and blue. So it's a simple code. This is all I want to leave you with. Perpendicular, it's retinal problems, that is schisis and detachments. Tangential, it's foveal problems, it's lamellar and full thickness macular holes. If you treat only one of the forces, the other will increase. So that is the concept. If you think your schitic change is not significant, you can go ahead and treat only the macular change with ILM and vitrectomy. If you think the schitic and the detachment change is more important, you may have to treat that first and secondarily treat your macular hole or your this thing. So by this simple code, this is what I'm saying, you need restoration of the foveal profile. That is your lamellar hole. Your foveal profile is lamellar holes and full thickness macular holes. You need to correct the retinal abnormality, that is your schisis and your detachments. The alteration of the foveal profile is by vitrectomy, and the alteration of the retinal and scleral profile is by buckling. Very simple code. Okay, thank you. Inviting you to our retinal imaging congress in Trivandrum in 22-23. It's a 2-3 day event just on retinal imaging. Thank you.
Thank you, Vani, for that excellent talk. Any questions from the audience? Yeah, please, Darius.
inverted flap and the detachment is very limited. So where do we train from? Because normally now we feel scared when we train from that hole itself that one of the flaps will come into the thing. And don't really feel like making a retinotomy in the posterior pole.
Yeah, so that's what.
The second question is, in such a case, what tamponade would you prefer, gas or oil?
Okay. So there are essentially two concepts towards that. One, these are concepts. That's still, the work is still difficult. That is, you can penetrate intact retina using a 39 gauge. That's it. You do not require, because the main thing of creating a drainage retinotomy is that you cannot do laser to close it, because there is RP atrophy. However, a 39 gauge is technically considered to be a self-sealing entry. So a 39 gauge attached to an active extrusion is the best way of removing fluid from a staphyloma. That's what I showed in the picture. The second question was, no, not through the hole. Nowhere through the, anywhere else other than the hole. Yeah. And the other question was? Okay. So for all practical purposes, the standard dictum is gas tamponades better than oil. Oil does not follow the contour of the oil. It's surface tension. Gas expands and fills the entire area, whatever the shape. Oil does not fill the entire area. It finds the least common arc. It's a bubble. It finds the least common arc. So if you have a staphyloma, it will touch both of the edges, and the lower part will be the same principle for inferior detachments essentially. Okay. So the concept of doing oil better for inferior detachments is not right. An oil underfill in an inferior detachment is worse than a gas underfill basically.
Only I have one quick query. You did a double staining of these membranes, like IVTA then blue at the same time you put, or you put IVTA first, do
IVTA
the PVD
first and then, no,
IVTA,
IVTA,
do the PVD,
no,
then the,
no, that is done. That's over. That's a different kind. Then we put IVTA, and then sprinkle this on the top and just. Yeah.
Because these posterior hyaloid and these membranes in myopics are very different. I mean, sometimes we don't get a proper staining as well, and they come as a piecemeal. They don't come as a single sheet. We don't know which part is ERM, which part is actual ILM, and it's so thin that sometimes a part of retina also might be into it. So only the staining is enough, or anything else you would like to?
See, one thing. No. See, it's basically when we usually peel off ILM, you don't even think about it. Here, as you peel, you have to know the nature of the thing you're peeling. Okay. The two simple clues is that usually the vitreous remnants do not tug at the retina as you pull it off. They're very adherent, but they do not cause the retina to come off. However, if you're pulling ERM, you can see the retina kind of folding along with it and peeling off. And these are the two components which are invisible to blue. They will be stained with IVTA, not blue. One other technique that was mentioned is that you start wholly away from the macula and start peeling ILM, and along with it all these components will come off.
Yeah.
So that's, you start way off of the posterior pole.
Regarding the crisis part, what you said, tangential and vertical tractions. Most of these myopes have degenerated vitreous. It's liquefied. And there's more tangential, but still you see the sciatic retina. I mean, I don't know how it actually helps in the vertical traction to be significant.
So there is one other concept called posterior cortical vitreous pockets, which means that the vitreous has been separated like a PVD, but these pockets are
fluid-filled pockets.
Fluid-filled pockets that move during microsaccades. So you have continuous tug on the retina or the macula, even while it is apparently not there.
I think
sorry to the recurrence of the schisis is seen after the vitrectomy also. So there's been a thought that it's a degenerative process which is unrelated to the tractional after if you remove. So most of our cases also we see that.